Right, so for those of you that are left, I will make it short and sweet. Well, certainly short. This presentation is about the results of the EVRS Endophthalmitis study. First, we have to, if you remember what the questionnaire was about, more or less the way it was structured, we had questions regarding primary, secondary, and tertiary treatment. So the baseline characteristics of the study, we had 253 patients, 64 doctors coming from 24 countries. This is the frequency. The major contribution was given from Turkey, France, Poland, and so forth, from several parts of the world. As you can imagine, the gender distribution is just about equal, male and female. And as you would expect, the age group is around here, between the 70s and 80s. 162 of these eyes out of 253 which developed endophthalmitis had cataract surgery or cataract-related surgery. So here you see a distribution of the each procedure, so cataract and IOL implanted, secondary IOL, or cataract with no IOL implanted. And here's a graphic representation. So this is very, I would say we just talked about this. So how many people were actually using prophylaxis with antibiotics at the end of the cataract surgery? About 40%. Where about 46% were not using any prophylaxis. Unfortunately, some of you have not answered, so I don't really know where this 14% should be placed. Were there complications? Yes, were there complications, and that's about 10% of the total if you add up the numbers. We had vitreous loss in about 80% of our cases. The IOL was dropped in 10%, and in about 7% we also had a nucleus drop. However, it's striking, and again, this we mentioned this morning, that we should not think of only cataract surgery because many procedures are now responsible for endophthalmitis. And of course, we all know about intravitreal injections, which account for another 46%. But look, here we have vitrectomy coming in with 30%. We generally don't think that we get this complication with vitrectomy, at least it is rather rare, but it occurs. Cornea surgery, trabeculectomy, glaucoma shunt, and I suspect, as I said this morning, this will be on the rise because the shunt actually becomes exposed after about 10 years. And since now a lot of tube surgery is being performed, I imagine that we will see a lot of these cases developing in the future. So a summary of the primary procedures which cause endophthalmitis, you can see here, mostly cataracts, mostly intravitreal injections, followed a third good place by posterior vitrectomy, and so forth. If we want to go a bit, I had to cut out a lot of the data to make the presentation shorter. You can find more data on the website, but if just taking into account cornea surgery, which is rather significant after vitrectomy as a runner-up for fourth place, we can see that most of the complications were associated with PK. Again, going back a second, what we mentioned today about removing sutures and the need to add iodine povidone in the eye, because this is a risky procedure. It can lead to germs entering the eye. So this is, I think it's quite obvious. We did not need statistics for this. The more injections you you practice in an eye, the higher the risk of developing endophthalmitis. So here we see that if we have an eye which has had more than 3 injections, we're running around 64% incidence. So obviously the aim of our work is to make people see. So what's the visual acuity of presentation? Well, you see that a minority presented with no light perception. Most people had between light perception and counting fingers. These are really the people we want to address rather quickly. A minority of these, 38 eyes, were greater than counting fingers, and you can see that a very small number was greater than 0.5, whereas most were placed in this 0.2 and 0.5. So obviously these are good eyes that can be, if addressed quickly and properly, can give excellent results. The cornea at presentation, again, what was said this morning about scraping the epithelium is not always necessary, because if you see, only a minority of the corneas in our study were actually completely cloudy, whereas mostly were either clear or somewhat cloudy, allowing you to carry out the surgery, if you plan surgery, without having to scrape the epithelium. Hypopyon, roughly most of the patients were in this set between 1 and 4 millimeters. And again, we had a question about if you could see the iris at presentation. Most irises were either completely visible or only partially visible. And it gives you an idea of just how severe the case at presentation was. Again, the same thing applies to lenses. So most patients were pseudophakic, obviously because they had their primary procedure as cataract procedure. In other cases, the lens was either not visible or somewhat obscured by the inflammatory process, or they were aphakic. So this is another important guideline, I think, that most physicians will adopt if the red reflex is present or not, in judging whether they can defer vitrectomy and just treat with injection, or if the case is more severe and perhaps they will opt for vitrectomy as a first line of treatment. So here we see that the red reflex again was present in about a bit less than half of these eyes, 40%, and it was not present in about 60%. I'm not sure that it really is a good guideline, but many of us use that. And again, was the retina visible at presentation? You can see the answers here. Mostly it wasn't. And obviously the disc and macula were also not visible. And was the retina detached? Now, either with direct observation or with ultrasound. And fortunately, most of the eyes did not have a detached retina. So we only had about a 5 or maybe a 12% incidence of retinal detachment. So most retinas were attached at presentation. Now, those eyes that have vitrectomy, we asked the surgeon to state whether or not endophthalmitis retinopathy was present, or endophthalmitis maculopathy. So about half of these eyes had retinopathy at presentation, and about a third of these eyes had maculopathy at presentation, again stating the severity of the case in question. Pain is another important guideline. Now, we know that pain can be less severe, although it's not an absolute rule, if we are dealing with primarily posterior endophthalmitis resulting from intravitreal injections, but that's not always the rule. So was pain present? Yes, it was. It was mostly moderate pain. Very few patients, about 17%, did not have pain. And very few, again, 15% had severe pain. So most of the patients present with moderate pain, and that, again, I think can help with a differential diagnosis with TAS. Primary treatment. So let's start with primary treatment. What did most of you do to treat these eyes? Well, most people went for intravitreal antibiotic injection. About 60% of the surgeons chose this route, and another 40% went for a different form of treatment. What antibiotics? Well, here we have all the options which were given on the questionnaire, and briefly, most people opted for the classical 0.1 vancomycin and 0.1 KEF. Again, the question, how many people, this was brought up today, how many people used steroids? As you can see, it's a good 60% of you using intravitreal steroids associated with antibiotics. So it's quite a good number. Which, well, again, some did not answer, but generally was triamcinolone. Was a vitreous tap carried out? Well, obviously the answer should be yes, and it was carried out in almost everyone, 80+% of the patients. So now we go to vitrectomy. So about primary treatment, how many received vitrectomy? And here you can see the frequency. Was retinopathy present? And roughly, in most cases, it was present, and maculopathy was also occurring in about 50% of these cases. What sort of instruments were used? Most surgeons opted for the 23 gauge vitrectomy probe, very few the 20, and surprisingly also not as many 25. Another question was primary treatment vitrectomy associated with suture at conclusion at the end. And the question was, do you use it? Do you use it? Don't you use it? Do you use it? But not for all three sclerotomies. So this is the answer. Most of you sutured the sclerotomies, which is interesting because most people used the sutureless 23 gauge. So obviously, it's a state of mind in which I think the surgeon is when he's facing a serious case like endophthalmitis. He wants to make sure that all things are in place. So sutures were used by most of you. And another important issue is about posterior vitreous detachment. Now, how many created a posterior vitreous detachment? About 46% of the surgeons actually actively determined vitreous detachment. Some were lucky enough to find it present, 34%, and some others did not give any information. And then another interesting question is, we were debating today, just how far should my vitrectomy extend? So on the questionnaire we differentiated anterior vitreous removal, cortical vitreous removal, but we had, because the numbers were not homogeneous and they would not form a category actually, we had to regroup them into core vitrectomy and larger extent vitrectomy. So we can see that most people went for, 80% were actually performing a procedure which involved removal of the peripheral vitreous as far as possible, anterior vitreous, so as opposed to just a core vitrectomy, which I think would make sense. And then another question regarded whether or not an opening in the posterior capsule was produced or not. And as you can see, very few people did this, most people not bothering. Another issue was the use of the tamponade, gas tamponade. As you can see, most surgeons did not use gas. If they did use gas, some sort of gas, a good 40% went just for air. How many people used silicone tamponade? Not many, about 30%. And this was 1,000 centistoke and 5,000. Very few people use Siluron. The majority using either 1,000 or 5,000 centistoke. Was antibiotic present in the infusion fluid? This was another question, and only 30% of the surgeons were using antibiotic actively in the infusion at the time of the primary surgery, which is interesting because as we progress into secondary and tertiary treatment, this number goes up for some reason. So the surgeons that were doing vitrectomy later on had slighter higher incidence of using antibiotics in the infusion fluid. If that's meaningful or not, I don't know, but the facts are as stated. And obviously a good 80%, 76%, used the antibiotic at the end of the surgery. And many people also were not happy with just doing that. They went for periocular antibiotics, whether they were subtenon, peribulbar, but they felt the need to put in some sort of added protection. And also, interestingly enough, most physicians were using systemic antibiotics. Very few were using, on the other hand, systemic steroids. So this is a bit confusing to people who, like me, do not know much about math, but I was told that essentially what this means is that we have 50% of the patients waiting less than 1 day, and if we look at the 90% number of the patients, they were waiting 1 day. As we move on, we see that 95% of the patients were waiting 2 days, and then this really doesn't count for much because it's a statistical number more than anything else. So what this chart means is that the waiting time for the first treatment for most patients was a day or less than a day. Okay, this means that it's less than a day. So most patients were waiting less than a day for treatment, primary treatment. So what were the treatments which were put in place? As we can see, most patients received vitrectomy. Intravitreal antibiotics follow very closely, and the combination of intravitreal antibiotics and vitrectomy is about, I would say, almost equal. It's 22% as opposed to 34, 37%. So we have these three groups which are more or less, I would say, equivalent, yeah, roughly. Secondary treatment, it's interesting that a lot of these patients had to go on to secondary treatment. And you can see that here we have 126 patients of the 253 which actually required secondary treatment. That's a good half of them. So today we were stating that one injection could solve the problem. Well, obviously it doesn't always work that way. So again, the approach was about 56% receiving as first-line secondary treatment intravitreal antibiotic injection. And again, the same antibiotics, and again, the usual concentrations. And here, the waiting times for 90% of the patients are actually quite long. As you can see, 80% receive their treatment within the first week, but then we have a number of patients that actually go up to 2 months, which is, to me, was quite surprising. Now, I know these are numbers, but the numbers mean something because people put the numbers on the questionnaire. So to me, this was very surprising, and I was scratching my head, not much hair, but I was scratching, saying, what, you know, it's surprising that after 2 months, some people are still being treated. And you'll be even more surprised when we get to tertiary treatment. So, and this I think we should, you know, could be a topic for discussion. So then again, the injection of steroids accounts for only roughly 30%. And obviously, as you can imagine, some taps were performed, but less, percentually much less than they were performed first treatment, presumably because these were eyes that had been tapped already and had been treated already with an injection. As you will see in the tertiary treatment, this number drops down dramatically to, I think, 2%, so insignificant. How many of these patients went on to postplanar vitrectomy? Well, we have about 38% of these patients going on to vitrectomy. And again, retinopathy was present in a good number, 60%. Maculopathy was present in another good number, about 50%. Again, what gauge did the surgeons go for? 23 gauge accounts for almost 70%, more than 70%. So most of the patients were using 23 gauge. Were sutures used? Again, yes, they were used by a good number, more than half of the surgeons. And what about PVD? PVD was created in about, again, half of those that responded to the question, and some, as usual, the other half, quite fortunate, found that PVD was present. Again, the extent of vitrectomy, most people going for a rather large vitrectomy as opposed to a more limited core vitrectomy. And just as we saw in the primary treatment, only few of you chose to deal with the capsule and create an opening in the posterior capsule. Gas tamponade, irrelevant. Most people use some other kind of tamponade, whether BSS or silicone oil. We'll see in a second. And here we have how many people used silicone oil, roughly 30%. So the others just left BSS. What sort of silicone oil? Well, again, we have a close call between 5,000 and 1,000, this time 5,000 being slightly ahead of the 1,000, but more or less they're the same. So we have that people using silicone oil are obviously judge this case as a serious case. They might have breaks or some other condition which makes the use of silicone oil necessary, and the two varieties are more or less equivalent in number. A slight increase in the people using antibiotic in the infusion. Now we're up to 37%, but most people still do not. And again, what sort of antibiotics? We know vancomycin, and here you see a graph representing what sort of antibiotics were used in the infusion fluid. And at the end of surgery, roughly 60% of the surgeons were using antibiotics to top off and finish their surgery. And this was the selection. You can see that vancomycin was associated with KEF, whereas in the people using just the antibiotic in the infusion fluid, it was just vancomycin. And again, a need to, I think, to strengthen the treatment with periocular antibiotics. We can discuss if this is useful or not, in your opinion. But a lot of people obviously think it is because most people are using it. Systemic antibiotics as well are being very widely used, 80%. Systemic steroids, again, once again, are not being used. So we go on to tertiary treatment. I'll try to be a bit faster. How many patients need to be treated a third time? 30%. That's 1/3 of the patients, which is surprising to me. So, and again, you see that this occurs for half the patients after about 3 weeks, and for 80% of the patients after about 70 days, 90% of the patients after 4 months. So we can discuss these numbers. I think they're interesting because I was not aware of them. So here we have, again, the approach to intravitreal injection antibiotics still represents 80% of the number has gone up from roughly from a predominant vitrectomy approach in the primary treatment to almost, I would say, an equal balance between vitrectomy and intravitreal injections in the secondary treatment, to a prevalence now of intravitreal injection, 80%, in the tertiary treatment. Again, same antibiotics, we don't change much on this. And again, steroids here are not used much, but they're used a bit more than they were in the secondary treatment. Was a culture taken? Well, obviously, the answer is no, and the reason being that it has been taken the first primary or secondary treatment. So these were eyes that already were identified for the germ, obviously, but the germ was still active. Vitrectomy, how many went to vitrectomy? About 26%. And again, we find a retinopathy present in about half of these eyes, and about 70% of these eyes have maculopathy as well. So more or less same numbers, prevalence of 23 gauge, and again, we have a good number of surgeons suturing at the end, maybe not as much as in the other primary and secondary treatment, but still suturing. PVD present in about 30% of the cases. Large vitrectomy, again, prevailing over core vitrectomy. Again, the same number of, I would say, people not addressing the posterior capsule, although the number has grown only slightly, but still the posterior capsule seems not to be an issue. And again, no gas tamponade, no relevant, no, it's not significant. But we have a good number of silicone, of patients being siliconed. Here we have 4 out of 11 patients being siliconed. And again, 1,000, 5,000, slight prevalence this time for the 1,000 as opposed to the 5,000. And this is interesting because you see that we have, as I mentioned before, we have an increase of the number of surgeons that use antibiotics in the infusion fluid on tertiary treatment. I don't know why, again, but these are numbers and you have to take them as such. I would just skip through this quickly because they're more or less the same. Again, systemic steroids. Culture yield was positive in about 50% of the cases. In another 50%, the germ remained unnamed, and this again is a problem. Most of the germs which are identified are, as we find in the literature, gram positive, with a good number of gram negatives, about 30%. these are data which are consistent with what we find in the literature. So finally, we get to the final part, which is what is most interesting, the visual acuity. So we started out with the visual acuity is light perception about 6% of the cases, but if you see, most cases here fall into a relatively good vision, 0.1 to 0.5. This is about 40%, and actually another 30% is greater than 0.5. So it's encouraging to know that if we approach these cases obviously early enough and appropriately, we can get some very encouraging results. The cornea, again, I think I could skip this part, where this just tells you how the cornea ends up, mostly clear, and we have some very hazy corneas at the end. The lens, mostly a pseudophakic. They were starting off a pseudophakic, but I have something to say about the lens as we move on. And the retina, fortunately, in most cases, was attached with only a 3% of the retina totally detached and another 3% partially detached. So 6% incidence of retinal detachment in these cases. Intraocular pressure, well, obviously we define hypotony here. It was a definition of less than 10 millimeters of mercury, and we have a great number of these eyes being hypotenuse, obviously because they've been through vitrectomy, but most of all because they've had a phlogistic process, an inflammatory process, which has affected the ciliary body. And the eyeball anatomy, how does this eye end up? Well, some were phthysical, some were enucleated, some were unfortunately pre-phthysical, so it's about a 10%, with 90% being normal. Now that was the univariate analysis. Now we have a multivariate, which takes into account several different equations. So if we look at the visual acuity, which is what, again, is most interesting to us, you have to read the chart like this. If you start with, in red is the presentation, the case at presentation, and in blue is the case at follow-up. So if they start off with no light perception, about 50% of the eyes end up with no light perception, but another 50% ends up with hand movement. Again, if they start off with light perception, 10% end up with no light perception, so there has been worsening of the situation. But as you can see, another 8% has light perception, 30% goes up to hand movement, 10% to 0.1, almost 30%, 0.2, and another 50% more than 0.5. This is very, very encouraging. So light perception can go up to 0.5 and beyond. Hand movement, again, you see 0.5, 26%, 0.1, 35%, 0.2, 0.5, 76%. So this is, you can see this in these tables where here is the initial presentation, the condition of presentation, no light, light, hand, and in blue, the darker the blue is, the better the condition. So just to show you, if we start off with no light perception, half of the patients end up with no light perception, just as I told you before, and half of the patients end up with, what does it say here? Light perception, okay? So this is how you read this data as you find it on the website. And this, again, tells you the better, obviously, that the presenting situation is, the better that the end result will be. But this is quite obvious. So what we can, the conclusion we draw from this is that endophthalmitis, as we've been repeating over and over again, is time sensitive. So the sooner you approach it, the better the results. So this is not very important to me. I mean, it just tells you what happens to the cornea. Obviously, if you start off with a very hazy cornea, you're more likely to end up with a hazy cornea. If you start off with a clear cornea, you're more likely to end up with a clear cornea. What I find interesting is this. The approach to the lens, the surgeons were rather aggressive because, true, there were many pseudophakics, but the people that started off with that were phakia, ended up with pseudophakia or aphakia. So obviously, this tells you something about the approach that the surgeon followed, feeling the need to remove the lens in phakic eyes to have a better approach to the eye and to the condition itself. Finally, I talked about the retina. We saw that most retinas end up attached. So of the detached retinas, several were reattached, either with silicone oil still present or with no silicone oil left, they were attached. Some were detached. Of the ones that were attached, only a few actually ended up detached, and a few still had silicone oil present. So the surgeons were doing a better job at reattaching retinas that were detached rather than being blamed for detaching retinas which started off as attached. All right? Conclusions. So what can we conclude from this study? Well, first we have a prognostic, the prognostic factors for the improvement of visual acuity. Now, the statisticians used logistic regression to evaluate the best strategy to improve visual acuity, and essentially the response was a binary response, a yes or no response to the question, was the final acuity, visual acuity, greater than counting fingers or not? This was the cutoff point. And several factors were considered, including age, cataract surgery, visual acuity, whether the iris was visible or not, the conditions of the cornea, the red reflex present or not, retina visible or not, disc macula visible or not, retina detached or not, and the amount of pain. So the conclusion to this first question is that the probability of having a final visual acuity greater than counting fingers is positively associated with the initial acuity being obviously greater than counting fingers, the cornea being clear at presentation, the absence of pain at presentation, and this is interesting, I would say, because it's vitrectomy as opposed to intravitreal antibiotics, and this is statistically significant. So this is, I think, the first important conclusion which was reached by the study. Second and final question was what prognostic factors would influence vitrectomy so as to make it more or less successful. And again, regression analysis was used to evaluate the strategy. And again, the question was how many eyes ended up with a visual acuity greater than counting fingers or not. And several factors were considered, and obviously the severity of the case, so the presence of infective retinitis or maculopathy, the gauge that was used for the vitrectomy, whether or not sutures were used at the end, what kind of tamponade was used, whether or not antibiotics were used in the infusion or at the end of the surgery. Many of these factors proved to be irrelevant, at least statistically speaking, and in the end, the probability of having a final visual acuity greater than counting fingers is positively associated with the use of small gauge, 23 and 25, as opposed to 20 and 27. We had some 27s. And negatively associated with, obviously, endophthalmitis, retinopathy, and maculopathy. And this is, again, a time-related issue. And this is interesting because I was thinking of this this morning. We were talking about what tamponade to use. And silicone oil tamponade is negatively associated with the results of the visual acuity. These are the numbers. This is the analysis that the statisticians performed, and you are very free to accept them as they are. We can discuss on them if you want. Thank you.
The cutoff for final visual acuity was count finger. If we look at 2100 or better, or 2050 or better, and so on in different levels, does that hold the same result that vitrectomy was better than injection?
We had to use this cutoff because the numbers, if you remember, that's a very good question, Ron. And that's what I asked the statisticians. But we had to create a model which could be applicable. Yeah. So what they said was, your numbers are so broken down that we don't have enough answers for the single categories. So they had to regroup so that it would be statistically significant. They had to regroup and then have a separation point, which we randomly selected at counting fingers. So I am not able to give you that answer because they have the data, but it has been regrouped. We can look at the raw data and try to get something from that, but they tell me it is not statistically significant because the numbers are too small.
And the other thing was the final outcome for the group, which had very good visual acuity to begin with, the 0.5 or better, or 20/40 or better. At the end, it wasn't as good as
50%.
Yes.
I cannot give you an explanation for that.
And that's different than the observation that we had with immediate injections.
Yeah.
Probably that was a factor of hours and hours of waiting for the injections.
Could be. Again, these are numbers, and they should really be. There's a lot of questioning. There's a lot of thinking to be done over these numbers.
Giampaolo, I think maybe the oil, I was thinking of the oil, it might be a selection bias because probably, as Murat showed, you use oil in the severe cases. So maybe that may be important explanation why oil was shown to be associated with a poorer outcome.
Yes.
Okay, that might be. Do you recall, I'm sorry, I've missed that in your presentation, what was the timing of second intervention, like 50% at what, or do you recall any of
and the average?
Yeah. Or the 90%?
80% got secondary intervention within the first week, 8 days.
Yeah, that's a very high number. So it's,
yes.
I mean.
But then again,
of course.
It's not an unreal scenario because in those places where, and you know that this, I don't know your experience, but Jen, in the UK, we tend not to perform vitrectomy as a first line, as the primary treatment.
No, but still, it's very unlikely that you inject again. I don't know, even
yes,
what's your,
but they do.
So you inject again?
Not me, but they do.
In the UK?
In the UK, yeah.
That's not my experience.
No, but every place has a different thing. But it's not an unlikely scenario. I see it happening. So my experience is limited to personal experience is limited to maybe 10 hospitals, but I see it happening. Yeah. So I was not surprised by this. I was surprised by the tertiary treatment, and to me, I didn't think anybody would get to that. And that's, if I remember correctly, it's about
90% at 72 days.
Yeah, but it's quite a number, isn't it? 30% of the.
But that might be just to deal with the opacities. So it's a completely different.
No, because we're talking about injecting.
Yeah, but I don't know.
Yeah, because again, people were injecting 3 months down the line.
Yeah.
So there's something very surprising in that.
Regarding the silicone oil, in addition to that selection bias, another explanation is this. When you put the silicone oil in a patient with endophthalmitis, the eye looks more quiet because we look through the visual axis, which is the big bubble of silicone in the
and you
middle,
can have the rest.
and that looks quiet. But those organisms and inflammation are actually sitting on the retina, exactly where you don't want them.
Yes, correct.
Giampaolo, I'm surprised with the high rate of hypotony. Did I see wrongly? I mean, it was something like 80% or something.
Yes, but then we have to understand what is defined as hypotony. So it was defined as below 10. We're not talking 2, we're talking 10.
But do we have the mean or do we have the severity?
It was not given. It was not given. It was not given. Keep in mind, Shingul, as they said this, well, several people said, to them, they're filling out this questionnaire because all this data is extremely interesting. But, it's one thing when we're discussing here. The other is when you send out the questionnaires and people don't fill them out because they're too long. They start and they stop after the 20th. They get to 10, 15 questions, they just close it and do not fill it in. And many, again, the numbers are there. We have to trust the people that have sent us the numbers because they're all our members. But some numbers may contain some sort of error. We don't know that. But again, we cannot, how can you judge that? So when you go too much into detail, although it would be very interesting to know these things, you lose people filling the questionnaires.
Giampaolo, thank you for this wonderful study. I have one comment. I totally agree with you regarding the peeling of the posterior hali, which is, in most of the cases, especially advanced and cases, is almost impossible to do this. Exposing the macula, I think, can be sufficient. But we did not address what is done to the vitreous base, because this is the site where the highest or the largest amount of exudation is present.
Yes.
How much the vitreous base was debulked, because this is a site where we can you cannot remove most of the and if you try to remove more and more, you may injure the underlying retina.
Yes.
So I think this is an important point in the management, and you have to put guidelines how much to debulk, I mean, the vitreous base. What do you think?
I think you're perfectly right. And we had this discussion with you. And the idea is that obviously there are two main structures which we want to preserve in the eye. One is the macula, and that are going to be affected first. One is the macula, the other is the ciliary body. So we want to strike a balance between just how much you can do in safety and how much it starts to get risky. So you can only remove what you see safely and what you think is to be removed. If you're guessing, this was my comment, if you're guessing, then you better not do anything. So when you start moving towards the periphery and you get closer and closer to a ciliary body that can start bleeding, and that's disaster, or if even worse, if you're indenting and then you snip up the retina, or even worse, the choroid, and again, detachment and bleeding. So it's better to leave some pus behind rather than to risk. But this is where my reasoning about being followed into it's like when the tanks move in and the infantry follows. So you move in with your vitrectomy probe, but you are followed by the infusion with the antibiotic. So wherever the vitrectomy probe goes, the antibiotic follows. This, I think, is a very good strategy to get even those germs that you do not remove with the vitrectomy probe. So I would say move as far to the periphery as you think is safe. Most people are doing large vitrectomies, as we saw from the study. So removing the anterior vitreous and going to the periphery. But do not risk, because it is better to leave some germs behind and go back in at a second, maybe a week after, 10 days after, rather to have an untreatable retinal detachment or hemorrhage. That's my idea.
Yeah, I can just underline this. And I had often made the experience that you might have hypotony because of some pus left to the ciliary body, and then you go in again and remove the pus, and then you get perfect normal pressure.
Yes, yes, and you can go in again and try to debulk whatever fibrosis has formed on the ciliary body. Sometimes that works as well if it's done in a timely fashion. So again, but you have to see what you're doing. This is really mandatory. Yes.
Hi.
Hi.
My name is Luke Tran from Amsterdam.
Right.
And I was also scratching my head at...
But you got here, I don't.
Yes.
So you get a lot more fun. Yeah.
Yes, this third injection after several months. I remember we had one case in our hospital where this patient had blebitis, and after 2 injections it was gone, but several months later he got it back, so we gave a third injection. And blebitis is the second most common reason for endophthalmitis, so it might be an explanation, I'm not sure.
You're right. We have a patient right now. Yeah, it's always a bit silly to talk about my patient, one patient, but you know, I think our profession is also made up of anecdotes. So anecdotal evidence. We have a patient now, again, in where I'm working now, that has had endophthalmitis. He's being treated. He's got pain. Continuing, the thing is going on. And to me, it's just, the endophthalmitis is still there. Subacute, but it's still there. But obviously, whoever's treating him has a different idea and has made a different diagnosis, which is uveitis now, some autoimmune. So they've got the experts following that thing. But I think it is a case of going back in, reperforming the vitrectomy. I have done vitrectomies down the line again, because I remember that even though I thought I'd removed everything, there were still things. One image I have in my mind now, you know what the spicula in the bone look like, you know, with all the strands like this. And I looked into the eye after a week, and there they were. They were all obviously vitreous which was left, and they were all, you know, cavities. And I said, well, I have to go back in, because obviously this is going to determine detachment, hypotony, everything else. So the germs somehow were better than the antibiotic, and you had to go back in. But 4 months is a long time, don't you think?
What we learned from this case was that we had to remove the bleb altogether. After
To remove, I'm sorry?
the bleb for the glaucoma surgery.
So this was associated with glaucoma?
Yes.
Yeah.
So after it was quiet, the thing we had to do was actually just clean out the bleb.
Yeah,
not let it come back.
well, we're not glaucomas, but I've had cases, similar cases. You have to remove the bleb, close it. I generally put a patch over it, actually, because if it's a trabeculectomy, you will not close it in any other way. So I put a patch, a tutu patch, or anyway, a porcine pericardium to close the trabeculectomy itself. And then, because the problem remains, it doesn't go away, generally, in my eyes, what I've done, I've had 3 or 4 cases, I put in a shunt, a valve, actually, Hammond valve, and it worked quite well for many, many years. But you're quite right, it has to be closed. And once it's gone, because the bleb is going to fail anyway. because it's going, it just becomes all fibrotic, so it's no good.
Thank you.
You're welcome. Any other questions, comments? Are you all very eager to go home? Of course you are. Okay, so thank you for coming. We have lunch, not the proper lunch you've been used to in these few days, but we have little sandwiches, so whoever's traveling can at least munch away something. And it's been wonderful to have you. Thank you for coming, and we'll see you next year.